Can you hear my voice? Anybody? If you can hear it, kindly put the thumbs up so that I can continue. So can you hear me? I'm waiting for your response so that we can begin the session. So I think it's 8 o'clock and we should begin our session. Very good evening to everybody. So I am Dr. Abhishek, your radiology faculty at Manipal MedAce, and the reason why we are here for is for the INICET May 2024 recall in radiology. So before we go ahead and talk about the intricate details of radiology in the exam, what was the first impression about the exam? Now it's been around 5 days that the exam was conducted, so possibly you'll be in a comfortable situation to tell what type of paper did it go. The initial impression of the exam was everybody was calling the exam to be very easy. And in fact, when I had a look at the exam paper, I also thought that according to the rest of the INICET exams, it was relatively easier. But an easy exam is never a good exam, because if the exam is easy, then the competition becomes very tough. In exam, we have three type of questions: one that are easy, ones that are with having mild to moderate difficulty, and the third ones are the ones which are severe or very difficult. That they are the ones for the toppers. So if we give majority of the questions which are easy or which are having mild difficulty, then obviously the competition itself rises. Now, second important thing about this, all the questions that we saw that we had in radiology at least were actually covered very extensively by us in our Manipal MedAce app, in the regular course, in the crash course, as well as in the notes. Secondly, one of the important surprising facts is majority of the questions, in fact, I should say in radiology, almost all the questions in radiology were a part of the previous year questions. I mean, either they were direct questions or they were indirect sort of questions, but they had something to do with the PYQs. And this is the reason why it's very, very important to have a look at the previous year questions at least 1 week before we have our exam. Because if there is a new question coming through, it is always going to be difficult and you might not answer it. But then majority of the others might not be able to answer it either. But if you're lacking on a PYQ, it's suicidal. Basically, everybody else is getting correct and you are the one who are getting it wrong. So PYQs are very, very important. This is important also for the upcoming NEET PG as well, where PYQs are going to play a very important role. Last but not the least, a very important thing which happened in this exam in radiology is a significant amount of integration, both horizontal and vertical integration that we saw. Out of the 12 questions that we are being asked in the exam, at least 3 were having direct integration with clinical sciences, let it be with medicine, with orthopedics, or with surgery. You're going to be talking about that cases as well as later. So it is important that we understand the pattern. Now we are moving ahead towards the next pattern, next type pattern. So we'll have a lot of questions which have integration of radiology with other clinical subjects, because this is what we do in the clinical picture as well. So let's begin our discussion, not waste any more time, and let's look at the first question. So the first question that was being asked in radiology was that of a patient who came to us with stab injury, and we had something like heart rate around 120, BP less, respiratory rate high, and on auscultation the breath sounds were reduced. So this was a clinical data that was given to you, but the most important key points in this particular question were: number 1, supine X-ray of the chest, and number 2 is the stab injury. Why they're important? Because when you have a stab injury, it's a penetrating form of injury. When you have injury to the chest, it is going to penetrate through your chest wall, pleura, and through the lungs. So either you can have blood dropping down into the pleural spaces, or you can have air dropping down to the pleural spaces. So we can have two options: either there can be blood or there can be air. So if there is blood, that is hemothorax. If there is air, that is pneumothorax. So we literally are left with two major options, either hemo or pneumo. So when we look at this particular X-ray, the most important thing that was highlighted was the basics of X-ray. We've discussed this many number of times. What are the things which cause opacification on X-ray? On this X-ray, we can see that the right lung field is homogeneously opaque, as if there is a veil-shaped opacity. Now, we've discussed this before extensively in our sessions, that the things which produce opacity are the ones which contain water, like pleural effusion, like consolidation, like collapse, or mass lesion. Now, in this particular case, we can have one of these four possibilities. Can there be consolidation in a patient with stab injury? Unlikely. So that's out of the question. Can there be collapse? Look at the position of the trachea. It was central. And why will lung collapse in a patient after having a stab injury? That is also out of the question. How will a patient develop a mass immediately after the stab injury? So it also is out of the context. So we're just left with fluid in the pleural space. The other two options which made some sense were diaphragmatic rupture as well as contusion. Pulmonary contusion, the word itself says that the lung has been contused or there is some injury to the lung parenchyma. So if there is going to be an injury to the lung parenchyma, it's going to affect a small part of the lung parenchyma rather than producing this veil-like opacity. As far as diaphragmatic rupture is concerned, we've seen this case before in our discussion that whenever there will be diaphragmatic rupture, you will have liver or some other bowel herniating into the chest. But there will be a part of the chest which will be normal. Now, the hidden clue. Why I'm saying this word is important, supine X-ray. Because if the patient is in erect posture, you will classically see the blunting of CP angle. But when the patient is lying supine, what will happen? The fluid will get on the dependent part, that is the posterior part of the pleural space, and as a result, you will get this veil-like opacity because the fluid has now spread evenly along the posterior aspect of the lung parenchyma. So, in patients who are having hemothorax with supine radiograph, many a times you might not have the conventional blunting of the CP angle, which was also not seen in this particular case. So, this is basically the same idea. The three cases that we saw previously when we were talking about the causes of opaque hemithorax in our app, where we can see that if we see an air bronchograms, it's consolidation. If we see flaring of ribs along with contralateral mediastinal shift, that is massive pleural effusion. And if we see trachea towards the ipsilateral side, it is nothing but collapse. And this is the classical appearance of pneumothorax. Pneumothorax will have air in the pleural space and air will be lucent. So you expect to find this lucency in the pleural space in cases of pneumothorax rather than opacification as we saw in this particular case. So again, in this case, just the basics of radiology need to be discussed. You don't need to go inside it. You just want to know the basic things which produce opacification, and then you can answer the question quite easily. So this is basic snapshot of the opaque hemithorax which we talked about previously in the app, just to highlight that all the things that we have been asked have already been covered by us. The next question. Now, this is a question which has been asked numerous times. I mean, in the last INICET it was asked in FMGE, and we discussed this question in great detail. That is, how to count the ribs, what are the anterior ribs, what are the posterior ribs. So let's quickly revise what we studied. So how are ribs located? You can just palpate your ribs on your chest for the easiest way. The anterior ribs are more oblique. The posterior ribs, as they come out of the vertebra, they are more horizontal. What was the arrow pointing to here? Arrow was pointing to the horizontal part of the rib. Now, this was easier question than what was asked previously when there was a rib fracture which was shown in the previous INICET exams, and then you had to tell which rib was fractured. Here the examiner didn't even want you to count the number of ribs, which can at times be difficult. He just wanted to know this rib, whether it's an anterior rib or a posterior rib. So since it was a horizontal rib, it has to be a posterior rib. Now looking at the other options, this cannot be the anterior rib. Why? Because this is the anterior rib here. What we see here, which are more oblique, these are the anterior ribs. On the other hand, we have two other options like costal cartilage and pulmonary artery. I think pulmonary artery, everybody knows, these are the descending pulmonary arteries. It can definitely not be the pulmonary artery. As far as costal cartilage is concerned, where does the costal cartilage lie? It lies along the anterior aspect of the ribs. So if you see something here which is along the anterior aspect of the ribs and is unossified, usually costal cartilage would not be ossified in young age individuals, so you won't be able to localize it directly. In elderly patients or in middle-aged patients, you can have costal cartilage calcification and then it can be seen. So this is definitely not costal cartilage, because costal cartilage again will be located along the anterior aspect of the rib. So I think this was an easy question, and mind you, rib questions have been asked quite frequently in the last 2 to 3 exams. So you can expect a question coming from ribs again in the upcoming NEET PG, and they can ask you anything. They can ask you fracture of the rib this time, or even they can ask you about the costal cartilage once it gets calcified. So just remember, if you see anything along the anterior aspect of the rib, which is the oblique part of the rib, oblique part of the rib is the anterior rib and horizontal part of the rib is the posterior rib. If you forget it, just palpate your own ribs in the examination hall and you will be able to make the diagnosis and clinch the answer. Now this question is a one-liner, has been discussed thoroughly by us, not only in our regular course but as well as in our crash course. Mount Fuji sign. Here the examiner didn't give you a CT scan. This is just for you to understand what Mount Fuji sign is. So Mount Fuji sign actually represents a thing which is called as tension pneumocephalus. We've talked about this before. What happens in pneumocephalus? Pneumocephalus means air inside the brain parenchyma or the cranial cavity. So there are two terms which have been given for it. Either you can call it as pneumo pneumocephalus, which is already written, or you can also call it as pneumocranium. Now, how can air come inside the brain parenchyma or the cranial cavity? There are two ways. If there is a direct penetrating injury, it can penetrate the dura and air can come inside the brain parenchyma. The other way is if there is a fracture of air containing structures in our skull, like paranasal sinuses, like mastoid antrum or mastoid air cells, which contain air on their own. So if there is a rupture of them, it can also lead to air escaping into the brain parenchyma. But that is normal pneumocephalus. If there is extensive amount of air inside the brain parenchyma, so much so that it pushes the brain parenchyma to the extent that it can herniate outside into the foramen ovale, then this is a surgical emergency, and this thing is called as tension pneumocephalus. Now, how to identify tension pneumocephalus? If you see extensive amount of air along the anterior frontal convexities and this is causing compression over the brain parenchyma. How can you judge compression? Look at the cortical sulci here. Can you see any cortical sulci? Here I can see sulci, here I can see sulci, but here I don't see any sulci, as if the frontal lobes have been compressed. Secondly, air has also come between the frontal lobes, leading to the separation of the frontal lobes. And this appearance of the frontal lobes, it just looks like a volcano, is called by the name of, yes, it is called by the name of Mount Fuji sign, because Mount Fuji again is a I hope you know this name. It is basically a volcano in Japan. So this is nothing but tension pneumocephalus. In normal pneumocephalus, you're not going to find any Mount Fuji sign. Fine. Thank you, Rahul. Thank you, Rahul, for the last revision result. Yeah, majority of the questions that we're talking about have already been covered in that crash course session. Anyhow, let's continue our session. Then we have other important features here. One is tension pneumothorax. What do you mean by tension pneumothorax? We've discussed this again. Whenever there is significant amount of air in the pleural cavity causing contralateral shift of the mediastinum, causing compression to the great vessels, it results in a case which is tension pneumothorax. The most important question is its management, and I hope this is the one question which can be again asked in your upcoming NEET PG exam. What is the management? The management is tube thoracostomy. Tube thoracostomy. I hope you know this. In children, it has to be done in second intercostal space in mid-clavicular line. In adults, you have to do it in fifth intercostal space in mid-axillary line, and thereafter the patient has to be sent for a ICD. So that is the management of tension pneumothorax that you should know. Then, is there an entity called tension pneumomediastinum? Yes, there is an entity in which there is so much of air in the mediastinum that it compresses the heart. The heart gets compressed, and there is a sign which is called as heart on earth or earth on heart sign, which can be seen. Now, this is another question. I hope it can be asked in the next coming exam, because they have tired of asking questions about tension pneumothorax and tension pneumocephalus now. Lastly, tension pneumoperitoneum. Again, it's a condition in which there is significant amount of air in the peritoneal cavity, which can occur after perforation. So this usually occurs after some instrumentation has been done and there is a significant amount of air which compresses the adjoining abdominal organs. All the signs that we see on a supine radiograph of the abdomen that we talked about, like Ligger's double wall sign, we talked about signs like liver edge sign, like Doji's cap sign, they are also going to be seen in tension pneumoperitoneum. So this was the basic snapshot from our again crash course, where we had discussed Mount Fuji sign quite classically, and we'd also be told that treatment of Mount Fuji sign is surgery, because it is an emergency situation. Now, next question. This question has got a bit of integration with your orthopedics as well. So, young male patient presents with thigh pain, and what is the diagnosis? Now, here the examiner can give you an X-ray. Examiner here give you a CT scan, but CT scan and X-ray behave the same. I mean, the image formation, the principles are quite the same. So whatever you're going to see on an X-ray, you're also going to see on the CT scan quite well. So let's quickly see what are the important things that we can make out of it. What is we are seeing is, this is the femur bone. I hope all of you will recognize it. You can see that there is a head of the femur here. And the most striking pathology here is thickening of this cortex. Now, we've talked about this extensively when we're talking about musculoskeletal infections. Whenever there is an infection to the marrow, that is internal part of the bone, it will result in formation of pus. This pus will break through the bony outline through openings which are called as cloaca, and it will result in chronic discharging sinuses. The rest of the bone, which is outside, will now become more thick, will have a dense periosteal reaction, and will try to contain the infection towards one side, resulting in what is called as involucrum. So in this case, we could see involucrum, number one. Number two, if you see carefully, as has been told by many students, that they could even see these small dense parts of bone inside the marrow cavity. So this is nothing but sequestrum. And there was one opening as well. As you can see here, there is another opening, which is nothing but the opening in the bone surface, which allows for the pus to pass from the marrow to the outside. And this is called as cloaca. So the answer in this case was quite simple. That was chronic osteomyelitis. I hope majority of you would have got it correct. Now let's look at the other options also. The first option that was given was osteosarcoma. Now osteosarcoma is the last possible thing. Why? Because sight is not favoring osteosarcoma. Osteosarcoma we've discussed that is going to be seen somewhere here. That is in the metaphyseal region. And whenever the examiner is going to give you osteosarcoma, mind you, he'll give you a very classical picture. So what is the classical picture of osteosarcoma? We will have Codman's triangle, we will have sunburst periosteal reaction, we will have a mass, a soft tissue mass. Then the second option was Ewing's. Again, Ewing's is one good possibility. Why? Because Ewing's is also diaphyseal. We've talked about it, diaphyseal. But Ewing's would present in less than 10 years. And secondly, it will have an onion peel type of periosteal reaction, not this type of solid periosteal reaction. So again, Ewing's is out of question. And the easiest to actually take out was osteomalacia. Osteomalacia is a condition which is characterized by gracile bones which are loosened because of lack of calcium. So this osteomalacia can never result in this type of thick cortical bone, and this is a classical case of chronic osteomyelitis. Sometimes the same question can be repeated in an X-ray form. So next time the examiner can give you the similar X-ray, and the X-ray actually shows you exactly the same picture as is being shown by the CT scan. What we can see here, we can see thick cortical bone which is involucrum, we can see some sequestra here, we can also see a cloaca which is an external opening for the pus. Some important key points that next time examiner can give you is the history of chronic discharging sinus. Remember, these are key terms that examiner can give you as hints, or examiner can also give you a hint of penetrating injury, which resulted further in chronic discharging sinuses. So it's a key word that you should remember, which are important words to highlight the presence of chronic osteomyelitis. So this is again the snapshot of our discussion where we discussed it in great detail, the presence of involucrum, the relevance of sequestrum and cloaca in cases of chronic osteomyelitis. Next question. Which of the following is true about CT scan? This is a hardcore radiology question, and it was, I think, the easiest of them all. We've talked about this n number of times, that there we have a Hounsfield unit scale which is given in CT. The Hounsfield unit scale is basically an arbitrary scale which gives a CT value to different objects that are imaged on CT. Hounsfield has given a value of 0 to water. That's an arbitrarily given value, and whatever is denser than water will be given a positive value, and whatever is lighter than water, less denser than water, you can say is going to be a negative value. So anything that is solid will be positive, like clotted blood, like bone, while anything which is lighter than water, like fat floats over the water, so it's less denser than water, will have a negative value, like lungs, lung parenchyma predominantly composed of air, that is lighter than water. And finally, pure air outside the lungs, all of them will have a negative attenuation value. So I hope you remember this option quite well, Hounsfield unit value of 0. Then the second important thing that was given was unfiltered X-ray beam is used. We've talked about this a number of times in talking about the X-ray machine or X-ray, the tube that we use filters. The filters are used in order to prevent the low energy photons from striking and forming an image, otherwise the image quality would be degraded. Dose in CT head is 20 millisieverts. Again, we've discussed this in great detail. It is 2 millisieverts. And when we talk about dose in cases of CT chest, it is around 7 to 8. And when we have CT whole abdomen, it's around 10. And when we have PET, it is around 25 millisievert. So this question is directly wrong. This option is directly wrong. And even if you didn't remember this, I think this was the easiest thing to remember. Option number A. Finally, the last option, which is the easiest to take off. I hope all of you would be knowing the first imaging modality in case of gallstone is never CT. Only nearly 10% of the gallstones can be picked on CT. The sensitivity of CT can go as high as 40 to 50%, but never as much as ultrasound. So remember this for the rest of the exams. Ultrasound is the imaging modality of choice for looking at gallstones, while NCCT is the imaging modality of choice for looking at kidney stones or ureteric stones. I hope you remember this, and you will remember this for the rest of the exams as well. So this is again a snapshot of the Hounsfield unit value, where we talked about the values of different entities. So 0 has been given for water, 45 to 65 is for clotted blood, 1000 for bones, minus 1000 for air, 8, that is minus 800 for lungs, and minus 60 to minus 100 Hounsfield units for fat. Next question. Which of the following contrast material can be administered in chronic renal failure? So let us first see what are the contrast material. Also, although this part also we had highlighted many times, I had actually had a great discussion on this. What are the contrast agents we can give in CRF? Let's again reiterate what we studied. Number one, ionic, iodinated, and non-ionic iodinated contrast media. So what are the different types of contrast media? The first one is barium, which is typically given as oral, or it is given as rectal route and in form of suspension. Now talking about CT contrast agents, there are two CT contrast agents. Either they can be ionic or they can be non-ionic, and both of them are iodinated. Iodine is a component inside them. For MRI, we have gadolinium. I hope you remember this. And then we have ultrasound contrast agents. What are ultrasound contrast agents? They are nothing but gas micro bubbles. And what is the gas that we use? We usually use sulfur hexafluoride, which is contained within the phospholipid shell. Now, if I ask, after telling all this, if I ask you, which of the following can you give in cases of patient in chronic renal failure? So obviously, if something is full of gas, it is going to be eliminated by lungs, so you can give it easily. And this is why ultrasound contrast agents, which are nothing but sulfur hexafluoride gas, can be safely given in patients with CRF or CKD. Now, why can't we give iodinated contrast agents? We had a great discussion about contrast-induced nephropathy. So these ionic or non-ionic contrast agents can result in contrast-induced nephropathy in patients who already have a deranged renal function. There was a question in previous year exam which was asked that which of the following investigations would you need to do before you subject a patient towards a CT scan? The answer was creatinine in this particular case. Similarly here, it is basically a modification of a question which has been asked previously. Why can't we give gadolinium? We don't give gadolinium because we are very afraid of a very important entity, nephrogenic systemic fibrosis. We don't have a cure for nephrogenic systemic fibrosis. It's a dreadful disease in which there is a fibrotic reaction which takes place all over the body, resulting in a really debilitated condition. So it is one of the worst things to have. So we cannot give gadolinium. We cannot give any of these ionic or non-ionic contrast media. Ultrasound contrast agents, which are gas microbubbles, can be given. And how do they work? They work because they get inside your blood system and then they can be taken up by the cells which are having an affinity to it, and then they can cause back scattering of the ultrasound waves. Now, next time the examiner can ask you something which we face a problem in our day-to-day life, like if a patient is having a raised alpha fetoprotein, if a patient is suspected of having an HCC, and the patient is also having a deranged renal function. Now, to diagnose hepatocellular carcinoma, you will be doing a triple phase CT. You need to do a triple phase CT, but the renal function is deranged, so you can't give contrast in those patients. So what is the next thing you can do? So for those patients, you can do a contrast enhanced ultrasound, that is called as CEUS, and you can again use the sulfur hexafluoride as an important ultrasound contrast agent because it is going to be excreted by lungs. It is excreted by lungs. And this is basically the snapshot of the image of what we talked about when we were having a discussion on ultrasound contrast agents, that this can be used in renal failure. And now for your further exams, you should remember the names of these agents as well. So probably the examiner is going to give you the name of either Levovist or Sonovist. These are two important contrast agents, or ultrasound contrast agents, that you should remember. Sono itself stands for ultrasound or sound waves, so you can remember it quite easily. Next question. Now, this was a modification of the question that was asked. It was a new question. It was a difficult one, I can say, but it was not that difficult if you would have understood, or if you would have eliminated the options, I should say, understood the basics of radiology and imaging. Which of the following anatomical variants is shown in this CT? And you have a arrow here, and an arrow is pointing towards something that we can see. There is a round shaped structure, and this round shaped structure is appearing white or bright, or in CT terms it is hyperdense. So let's go back to the basics. What are the things which appear dense or hyperdense, I should say, or bright on CT, and what are the things which appear hypodense or black on CT? So we have talked about this n number of times, that there is a mnemonic called as BBB, that is blood, standing for clotted blood. B is bullet, that is metal, and third B was barium, which indirectly meant contrast. So these are the things which appear bright, and anything which is filled of air, we've talked about this, we've talked about Hounsfield units right now, will appear as black. Now this thing, can you tell me, is appearing white or is it appearing black? It is appearing white. So it has to be either of the three. Blood we use specifically for clotted blood in brain predominantly, although bleeding anywhere will look hyperdense. But you think it can be a bleeding? No, it cannot be bleeding. Bleeding cannot be confined so well. And secondly, examiner has told normal anatomic variant, so it's not a pathology. It can definitely not be a bullet. Then third one is left with this contrast. So it means it's a contrast filled structure. Now one thing which is contrast filled has to be a vascular structure, because contrast gets only in vessels. And secondly, this is vascular. Why? Because it is taking the shape of a vessel. So what are we left with? We can have either a right aortic arch or aberrant right subclavian artery. We cannot have duplicate. Esophagus is a muscular structure which is filled with air. So it will appear black. It will appear hypodense. Similarly, tracheal diverticulum, a diverticulum of trachea, outpouching of trachea. So trachea is filled with air, outpouching will also be filled with air. So again, you can easily cancel off two options just on the basic knowledge of CT. Now comes the difficult part, how to actually tell whether it's a right aortic arch or it's an apparent right subclavian artery. So we've discussed about this. Arch itself means something which is arching from anterior to posterior. Normal aortic arch is also arching in this direction. So here what we are looking at, here we're not looking at any this type of arching type of structure. We can just see a round shaped structure, and it is a small caliber structure. It is aortic arch would be a large caliber structure. So by the process of exclusion, we can clearly say that's an apparent right subclavian artery. Now, if we want to know the anatomical basis, again, we've discussed this before as well. This central air-filled structure is trachea because it is black, it is hypodense. We can see a vessel here which is nothing but the right brachiocephalic vein. This is the left brachiocephalic vein, and somewhere down in a lower section they both will combine to form the SVC. This is the left subclavian and the left common carotid artery. So we have an abnormal vessel which is lying posteriorly, just anterior to the vertebral column. Since the examiner itself has said it is a normal anatomical variant, it is a normal vessel lying at an abnormal location, or a normal vessel lying at a normal location. Then we also see a small collapsed structure which is just posterior to trachea. We have two pipes, but trachea is most anterior. We've talked about this before as well when we were talking about mediastinal masses. So what is the thing which is pipe and which is seen posteriorly? The thing which is seen posteriorly, it is going to be the esophagus. So in this particular right contrast filled structure is lying posterior to the esophagus. So it is again a classical aberrant right subclavian artery. And next time examiner can ask you about dysphagia lusoria. So this is a term which is given for dysphagia which is caused due to the aberrant right subclavian artery because of its compression over the esophagus, because it is now coursing in a retroesophageal direction. So these are few images. Next time the examiner can give you this type of an image as well. Now what is happening here is that the aortic arch is seen on the right side. Now this is an arch because now we can see it arching from posterior to the anterior. Similarly, in this image what you can see, now you can see a black colored structure. Now this is a black colored structure, so it must be filled with air. And the most important prominent air filled structure anteriorly is the trachea. It is seen in combination with the trachea, possibly communicating with it. So this is tracheal diverticulum. So you should remember these things as well because these are potential MCQs in the upcoming exams. Next one. This question has been asked so many times, and we are sure that this is going to be asked in one form or the other this time also. But this time it was asked in an easier form. An elderly patient presents with halitosis, regurgitation, weight loss for few months. Barium swallow images are shown below. What is the likely diagnosis? So the diagnosis could be achalasia cardia, number one. Number two, esophageal carcinoma. Number three, diffuse esophageal spasm or Zenker's diverticulum. I think this was the easiest for you all, must have been the one. You can see that there is a grossly dilated esophagus, which is showing tapering. And this type of a sign is called as a bird beak sign, typically showing tapering in the region of the GE junction. So I think this, everybody of you would have got correct. This is a classical case of achalasia cardia. And esophageal carcinoma would present in form of an irregular narrowing, which will result in shouldering, irregularity of mucosal edge, and you won't find this smooth narrowing. If you find this smooth narrowing, that can never be malignancy. Diffuse esophageal spasm presents in form of typical corkscrew esophagus, Curling's esophagus that we've talked about. I'll be showing you that later on. Zenker's diverticulum is basically a diverticulum of the upper esophagus, and it is an outpouching which occurs between the inferior constrictor and the cricopharyngeus. It is posterolateral as seen at the level of C5-6. Although it can also present with halitosis, but in this case you will find a diverticulum, and that's located in the proximal part of the esophagus. So this is again a clear-cut question, again snapshot of something which we were discussing before. It is a classical question. Many a times these type of questions keep on being repeated. So I hope that in the upcoming NEET PG also we can get similar question on achalasia. So important thing in achalasia is that the investigation of choice you need to remember is the manometry. These are the three other differentials that were being asked. So this is the esophageal carcinoma, where you can see the typical rat tail appearance, and we can see irregular narrowing which is concentric. This narrowing is associated with upstream dilatation, typically having shouldering, all the features of malignancy, and we can also see that some amount of contrast is passing beyond. This is the classical of Zenker's. Why? We can see the cervical vertebra, and just at the level of C5, C6, we can see an outpouching along the posterolateral wall. I hope everybody of you will be able to recognize it. This is seen at the level of C5, C6. It's posterolateral in location, occurs between inferior constrictor and cricopharyngeus. And finally, this is diffuse esophageal spasm, where you find corkscrew appearance of the esophagus. The only question that can be asked here is investigation of choice. Because it is a motility disorder, the investigation of choice here is going to be a manometry. So I hope this is going to be clear with all of you. These three images, again, very important, because in the next or upcoming NEET PG exam, again, you can have one question from this particular entity. Now, we'll talk about those questions which had a significant integration with the other parts of the clinics. Like we had three questions, one from which was having a very strong integration with medicine, the other was integrated to surgery, and one of them was integrated to orthopedics. So the first is the question which has been closely integrated with surgery. So a 35-year-old male presents with 2 ER after injury following RTA. He was unconscious for a short period of time. Now this is a very classical description of lucid interval. Now patient was unconscious, but after a certain period of time, patient regained consciousness. Lucid interval, we've discussed this before as well. On waking, he had severe vomiting and was drowsy with a low GCS, 3CS was 10. On examination, his pupil was dilated on one side. Dilatation of pupil means midline shift has started occurring. Now, this is all clinical data, which I hope would be better covered in your surgery. Let us focus on the radiology part of it. CT head of the patient is shown. What is the management of this patient? So, our part as far as radiology is concerned is to identify the pathology, and then after identification of the pathology, we can go towards the question and the answers. So what we are seeing a very well demarcated biconvex shaped structure, which is looking outside the brain parenchyma and is showing very, very bright appearance. We talked about this, BBB. So since it's brain and since there is a history of trauma, it has to be clotted blood. Now, if there is blood outside the brain parenchyma, we're left with three differentials. Either it can be SDH, or it can be EDH, or it can be SAH. Because it's having a biconvex appearance, it is classical of EDH. And what have we in the clinical question? There's a hint which has been given to us, that is presence of lucid interval. So now we are sure that we're dealing with a case of EDH, but the examiner doesn't want to know about what is the diagnosis. He wants to know the management. So again, depending upon the power of exclusion, you have an EDH, you can definitely not give anticoagulants to such patient. Otherwise, it will increase the size of the bleed. If there is any bleed anywhere, the last thing you would give is an anticoagulant. Had it been an ischemic stroke, then this thing could have been thought about. But for bleeds, it is completely contraindicated. Then we are left with three other options: immediate surgery, observation, and mannitol to reduce the intracranial pressure. So again, we've discussed this before. When you look at a large EDH, we have to see whether it is causing a midline shift or not. In the question, we have been given a hint that there is possibility of a midline shift. And if we use the CT image, if we draw a straight line which is passing from anterior to posterior, we can see that there is a midline shift occurring towards the contralateral side. I hope everybody of you will be able to see. If there is a significant amount of midline shift associated with clinical deterioration of the patient, then it is an indication for surgery. So we can have either surgery or mannitol. But mannitol will not be helping us in this case. When there is a significant amount of midline shift which is occurring, obviously you can give mannitol, but you cannot save the life of the patient with mannitol. To save the life of the patient, we need to do an immediate surgery. We can evacuate this hematoma. Without evacuating, the patient cannot get improved, because not only radiologically but clinically he is now having signs of deterioration. He is having signs of impending herniation. Once there is a question of impending herniation, there is nothing that we are left with. You will have to operate upon the patient. This operation can be done in two forms. You can either open the skull up, or you can do a per hole surgery. That's not going to be discussed in your surgery session. So this is again the session snapshot of the session where we discussed this in great detail. We talked about this talk and die and the lucid interval picture as well. And a few pearl points that you should know about extradural hematomas is that they do not cross sutures. They do not cross sutures. Number one. Number two, they can cross midline. They occur because of high impact trauma. An important thing which was given was 35-year-old. So we've discussed this before as well, that EDH are going to be seen typically in young patients with high impact trauma, while SDH is going to be seen in relatively elderly patients even with trivial trauma. And this occurs because of injury to the middle meningeal artery. And these are the two important clinical syndromes that we talked about, that is talk and die and the lucid interval. So I hope this pretty much sums up everything about extradural hemorrhages. The shape is typically going to be biconvex. And this is basically the three types of the extraaxial bleeds that we can see in brain parenchyma. So we already discussed about this. This is typical biconvex shape. So this is nothing but EDH. If you find a similar appearance, but it is having a crescentric shape and it is seen crossing all the sutures. Why I'm saying it is crossing the sutures? Because it is seen over the frontal lobe. It is also seen over the part of the parietal lobe. So it has crossed the sutures. So this is a classical of subdural hematoma which can cross sutures, but it usually does not cross midline. It occurs typically in elderly patients. It can also occur in patients who are using anticoagulants. It occurs due to the rupture of the bridging cortical veins. And finally, if the examiner gives you this type of image, I know all of you will recognize it. There is extensive amount of this hyper density which is seen spilled over the cortical sulci everywhere. It's coating over the brain parenchyma. It is a classical appearance of subarachnoid hemorrhage. And in subarachnoid hemorrhage, if it is non-traumatic, the next investigation you're going to do is to do a CT angio in order to rule out presence of an aneurysm. Next question, again a question which had a very strong integration with orthopedics. Identify the pathology shown on this X-ray. Now, why is this question important? Because it highlights something which is called as patella. Patella has been recently asked. I mean, different forms of patella, like bipartite patella has been asked previously. Now they're actually asking you a question directly based upon the fracture of patella. What are they actually showing you? So we can see a faint margin of patella here, and within the margin of patella, we can see some faint lucency. Again, it's very difficult to diagnose it, but this is nothing but a patella fracture. Why cannot it be a tibial condyle fracture? Because the tibial condyles look all fine. I mean, there is nothing wrong with the tibial condyles. Rheumatoid arthritis, it is again out of question. If the examiner wants to ask you anything about rheumatoid arthritis, he will give you a hint that this is a patient who is young female. Remember, young female, and in all probability, he will give you an X-ray of wrist, because involvement of this joint, that is knee joint or peripheral large joints, is very uncommon in patients with rheumatoid arthritis. So probably if the examiner wants to ask about rheumatoid arthritis, this is the last X-ray that he's going to give. Heme arthrosis, again heme arthrosis is something which we don't diagnose on single X-ray. You can have indirect evidences of hemarthrosis in which there is widening of the intercondylar notch, but again, it's something very difficult, very rare. So we should look for the easy things or the easy diagnosis to be made. So this is a classical case of patellar fracture. And why it's important? Because previously there was a question which was asked upon this bipartite patella, which appears in form of a two different bones which are closely aligned to one another, which are separated by this thin lucency, as you can see, and most of the times it is going to be located superlateral. So we talked about this before, and then we had talked about the Sope's classification also, which is given for bipartite patella. So remember, because patella is something which is in highlight these days, so probably you can get a question about patella in the upcoming NEET PG exam as well. The view that we do for identification of patella fractures is basically the skyline view, as you can see, and it is also done for the identification of bipartite patella. Now, the last question from radiology was this. Again, it had a very, very strong integration with medicine. A patient presents with fever, chest pain since 1 month, breathlessness, and chest x-ray of the patient is shown. So the most important part was this chest x-ray, and then there were some questions which were asked or some options which were given which were related to your medicine part. So what do we see on this x-ray? We can see a significantly increased cardiothoracic ratio, but this is not just increased cardiothoracic ratio. What we see that the heart is more wider towards the lower aspect, and this is a classical appearance of what we've talked about. This is a classical appearance of pericardial effusion, and the different appearances of pericardial effusion that we talked about on an x-ray chest, that is an erect x-ray chest PA view, were water bottle, money bag, flask shaped. So again, recently I've seen that many questions in radiology have been asked from pericardial effusion. So remember, this is again very, very important and high-rise topic that you should remember. It's going to be high yield, and probably one question you can expect it from pericardial effusion in your upcoming NEET PG as well. So amongst the diagnosis, I hope that the answer was loud S1. This is something we don't expect, but this is something which your medicine faculty is going to teach you or tell you in a much better fashion. So this was the slide, basically the snapshot of the slide where we talked about pericardial effusion. We talked about the investigation of choice, which is basically ultrasound in this case, and the various radiological features that we can see on an X-ray as well as on a CT. So this is another image just to show you the future questions that can be asked. This is the classical appearance of pericardial effusion. If you see this type of calcifications, this type of increased opacity along the peripheral aspect of the heart, it represents nothing but it represents calcifications which are occurring in the peripheral aspect, calcifications which are occurring in the pericardium. So this is a classical case of constrictive pericarditis. And this is again a potential question, because this time they ask something about pericardial effusion. Probably next time they will ask you about constrictive pericarditis. It is calcific constrictive pericarditis, and the sign that you see here is the egg in cup appearance. So with this, we come towards the end of our discussion on this INICET May 2024 recall. I hope that there were so many things to learn from this particular session as well, but specifically because we are now aiming for NEET PG. The most important thing that I could make out of it is, although the exam was easy, but the role of previous year questions is paramount. It is very, very important that you keep discussing, you keep learning. For the last 1 week, you should keep revising the PYQs. That's most important, because majority of the paper is going to come out of that. You can afford to lose one of the new questions which are asked, but you cannot afford to lose a previous year question, because everybody else would get it correct. So I hope you will just go through our Manipal MedAce app. You look at the crash course, because in the crash course has been handcrafted in such a way that we've taken all the previous year high topics and previous year questions, and this is the last resort, as I can say, for the preparation. It's going to be one of the best things that you can go through. So thank you very much. I hope you enjoyed the session.